All right, so here we are. This is an MS Views and News program. It is called Understanding More About Disability Progression in Multiple Sclerosis. Our guest speaker tonight is Dr. Patricia Coyle. This program is sponsored solely by Sanofi, and people will start hearing more about Sanofi as time goes forward, in case you don't know about them already. So in addition to Sanofi being our sponsor, our supporter of this program, I also want to thank the National MS Society for helping get the word out about this program and for doing all that they do. Patricia Coyle, MD, is Distinguished Professor of Neurology, Vice Chair for Academic Affairs, and Director of the Stony Brook Multiple Sclerosis MS Comprehensive Care Center. She earned her medical degree and completed her residency and chief residency in neurology at Johns Hopkins University School of Medicine in Baltimore, Maryland, where she also completed a 2-year fellowship in neuroimmunology and neurovirology. God, that's a tough word for me to say. Her areas of expertise include multiple sclerosis, neuroimmunology, neurologic infectious disease, in particular Lyme disease. Dr. Coyle has held multiple leadership positions at the American Board of Psychology and Neurology, the American Academy of Neurology, the American Neurological Association, and the National Multiple Sclerosis Society. Thank you, Dr. Coyle, for being here. And Dr. Coyle will be presenting for 45 minutes, and then we will do Q&A for another 45 minutes, and then call it a night. Thank you.
So I'm going to be talking about MS disability progression for about 45 minutes, and then we'll bring Stuart back on to run the Q&A. And I have 7 components. We're going to start by talking about the new concepts about MS. We are thinking about this disease differently at the current time. Then we'll talk about how MS worsens. It's a multi-domain concept of how people with MS can worsen. What's the pathogenesis of progression? Why is that important? Because it will help design better therapeutic strategies to treat progression. We realize that's a big lack. We have multiple disease-modifying therapies for relapsing MS, but much more limited for progressive MS. How to detect worsening? What is the current treatment approach for progression disability? What are future needs? And then we'll summarize at the end as we then go to a Q&A. So MS and new concepts. There's a lot going on. Several weeks ago, the new diagnostic criteria were published, finally. They're the 2024 revised McDonald diagnostic criteria, the biggest revision to the diagnostic criteria since they started, adding optic nerve as a preferential site, allowing the diagnosis of MS to be made in clinically silent individuals or those with atypical presentations, a new spinal fluid test added, kappa-free light chain index that I think is likely to replace oligoclonal bands, the fact that there are 2 MRI diagnostic paradigms looking for a central vein sign in the CNS white matter lesions, which is found in MS and virtually no other diseases, is going to improve our diagnosis when people are referred simply for abnormal MRI scan. As well, paramagnetic or so-called phase rim lesions or pearls, which are features of MS that you really hardly ever see in other diseases. So there's a lot going on from a diagnostic, and this is brand new, just published a few weeks ago. We now think of MS as a homogeneous disease, not different subsets, but a homogeneous disease and a continuum of MS, no matter whether you have relapsing or progressive MS. We have recognized clinical phenotypes, relapsing MS, primary progressive, secondary progressive MS. They're being criticized, and there are individuals that are looking at perhaps changing them because the definitions for clinical phenotype have been clinically based, and they believe they should be biologically based. So there may be a change in our clinical phenotypes. Progressive MS, we now consider that's the identical process, whether you have primary progressive or secondary progressive. That's smoldering inflammation, neurodegeneration. That's progressive MS, and it's not any different we believe, between primary progressive and secondary progressive. The implications for that, if you have a treatment that works in primary progressive MS, it should work in secondary progressive MS and vice versa. So treating progressive MS, you're treating the same thing. And we're seeing more and more progressive studies admit both primary progressive and secondary progressive. And subjects may move in and out of progression. We didn't realize that, but people may be relapsing and progress, and then they move back from that and they don't continue to progress. So it's not an absolute. The concept that if you were relapsing and you went into secondary progressive, you showed progression over 6 months plus, that was inevitable that you would remain progressing, appears not to be always true. And we now think of MS as having two distinct neuropathologies that I'll go into in just a minute. So how does MS worsen? In several different ways. It worsens with aging. Understand, from about 30 to 40 years of age, we're in the descendancy with our brain aging and starting to see atrophy, and that becomes even more accelerated after age 60. So aging is a factor. Someone who is older, that's a difficulty. They're not going to be able to handle things as well. Things that damage CNS reserve, CNS, the central nervous system, the brain, the spinal cord, the optic nerve. MS hits the central nervous system, not the rest of the body. There's no direct pathology in the rest of the body. But how can you damage CNS reserve? And this refers also to how well you will age. If you have poor lifestyle choices, if you have a lot of comorbid conditions, if you don't follow a wellness program, that's going to be harmful. This should be considered an independent treatment for MS, and particularly progressive MS. And then we're going to talk about two different direct MS ways to worsen. One is relapse-associated worsening. Somebody has a clinical attack and they never make a full recovery from it. That's possible. A stepwise deterioration, that is considered RAW, R-A-W, relapse-associated worsening, directly due to the MS disease process. And then there's progression independent of relapse activity, P-I-R-A, or so-called PIRA. That's the neurodegenerative gradual deterioration, smoldering inflammation component where the patient is gradually worsening. RAW and PIRA are independent entities, but both can contribute to the development of worsening. And then, of course, MS symptoms that are bad, that are interfering with quality of life, et cetera, they also allow MS to worsen. So there are multiple planes on which MS may worsen. Okay, this is a very interesting concept. Brain predicted age differences. We have a chronological age, that's our birthday. But we also have a biological age, and you can see a mismatch. There are various ways to examine the biological age of somebody. This happens to be one. It used artificial intelligence and machine learning to make the computer program smarter, learn from what it did well and what it didn't do well. And this really analyzed multiple MRI scans, hundreds, thousands of MRI scans, and it aged the individual based on the MRI of the brain, based on volume loss, based on atrophy. That gave a biologic age to compare to the chronologic age. Now understand, if the biologic age minus the chronic age is a positive, that's bad. The brain is actually older than the person's true age. You would like the biologic age to be less than the chronological age. That would indicate that that person had a younger central nervous system. So it turns out, and this is just one of a number of studies, there are different ways to age. It doesn't have to be based on brain volume loss. They looked at relapsing MS, including first attack, clinically isolated syndrome, that was 1,200. They looked at 120 primary progressive MS patients, 150 healthy controls. The brain pad was increased in MS compared to controls. In the primary progressive MS, they were 11 years older than their chronological age. The secondary progressive, 13 years older. The relapsing MS, 12 years older. The CIS, the clinically isolated syndrome, first attack, 7 years older. And they found that that seemed to be a pretty good measure, your brain pad and having a bad brain pad predicting a worse course. And the development of, on an annual basis, worsening brain pad predicted disability. This may be a measure that we look in the future. We may be aging people to look at their biological age versus their chronological age and see how we can develop improvements in people actually having younger central nervous system. Now, sometimes people ask, well, what are lifestyle choices and wellness program? What are you talking about? Not smoking or vaping. That's terrible for MS. Nobody with MS should be smoking or vaping. Get normal level vitamin D levels. At least in Caucasians, vitamin D deficiency increases risk for development of MS. So it's probably a very good thing to make sure somebody has normal levels. Vitamin B12 level, we like to see that over 400 because low normal can have a relative deficiency in a minority of individuals. A regular exercise program, absolutely critical, absolutely key. Optimum weight and BMI. A healthy, non-inflammatory diet. No single diet has enough data supporting it to say everybody with MS should be on this particular diet. But you know a healthy diet, a non-inflammatory diet versus an inflammatory diet, they are not good. And good sleep hygiene. This is all part of a wellness program that actually helps anybody age better, but that may become critically important for the MS individual. Now, what about raw and PIRA and disability? And let me go over some definitions. We talk about disability worsening versus disability progression in MS. In general, disability worsening is used for relapsing MS populations and disability progression for progressive MS populations. So generally, that will be a division. Then we talk about confirmed and sustained worsening. What do we mean by that? There's a good day, bad day phenomenon in MS. If I examine somebody in the morning and I examine them at the end of the day when they've had a very arduous day, the chances are their exam won't be as good. The chances are I'm going to pick up deficits that I wouldn't have seen in the morning. So you have a good day, bad day phenomenon. If somebody is really worsening, you want to see it confirmed over time. Probably ideally over 6 months, over 24 weeks, but at least 3 months, at least 12 weeks, and stretching it confirmed over a year. That's much more meaningful to deterioration where somebody can worsen and then get better. So is the disability confirmed or not? And then sustained means at the end of the study, if they worsen during the study, they're still worse. They still show that disability at the end of the study. So that may say that it's lasted years. That's much more genuine progression. So that's what confirmed and sustained mean. Now, it turns out that raw, that relapse-associated worsening is the major type of worsening in pediatric MS and no other subset of MS. It's not the major form for any other subset of MS, just the young people with MS. Why? Because that focal inflammatory relapsing component is maximum with young age and early disease. So when pediatric MS patients worsen, it's going to be typically by raw, relapse-associated worsening. Otherwise, PIRA dominates. PIRA is how most MS individuals become worse. It certainly dominates in progressive MS, but it also dominates in relapsing MS once they're at least 2 years into their disease. So when you see confirmed disability worsening in a relapsing cohort, the majority of those patients worsen by PIRA, not raw. And that's an important thing to think about. We haven't accepted a universal definition for PIRA. In the hard studies that are published, generally it involves evaluation of what's called the Kurtzky Expanded Disability Status Scale, EDSS, a 0 to 10 scale based on the neurological examination. 0 is you're completely normal, 10 is you're dead. Okay, so the higher on the scale, the worse the neurological exam. So there's no uniform definition for PIRA, but PIRA is now recognized to occur in relapsing populations, and it may occur very early with little to no overt disability. So you have to be on the lookout for it. They actually referred to it as silent progression, which was inaccurate. It was defined by worsening on the EDSS, so it wasn't silent. But patients didn't realize it, and very good, astute MS neurologists didn't realize it because they weren't looking for it. They didn't expect it. So we're going to hear some statements that would help somebody understand that there may be progression ongoing. So let's talk about pathogenesis. We now recognize in MS there are 2 distinct CNS inflammatory processes that damage tissue in the MS individual. And we believe both of them are present in virtually every MS individual early on. Okay, that gets to the homogeneity of the disease, that there's nobody that doesn't have a progressive component. There's nobody that doesn't have a relapsing component. You see both neuropathologies there, but one may dominate at various times for reasons that we need to find out. The first neuropathology involves acute focal inflammation, where blood immune cells cross a blood vessel, cross a vein, and cause local damage with demyelinization and injury to nerves and axons and exciting glia. That happens around a small blood vessel. This might present with a clinical attack. It would certainly present with enhancing lesion, and then with a macroscopic lesion that you could visualize on the MRI scan, hyper T2, hyperflare. That's the underpinnings of relapsing MS. So this is the neuropathology that is causal for relapsing MS. Blood immune cells, lymphocytes moving in and causing damage around the blood vessel that may cause a clinical attack and causes macroscopic MRI lesions. And there's an age relationship. It's maximum at a young age and falls over time. It's maximum in the early years of MS and falls over time. In fact, the issue is, can it burn out in some individuals? If you reach a certain age, could you no longer have this relapsing acute focal component? And therefore, you would no longer need to continue a disease-modifying therapy for relapsing MS. So this has been raised as a possibility, and we're beginning to see studies that are trying to examine whether there are some people who have not shown progression, who've remained relapsing. Do they reach a certain age where it's no longer active and they could actually come off treatment? And people are really looking for signs of that and studying that. The other neuropathology underlies progressive MS. And this is the smoldering within the CNS inflammation with neurodegeneration. So this is quite different from that acute focal, depending on blood systemic immune cells. This is within the central nervous system. And what it also has an age relationship in that the clinical appearance of progression, gradual worsening, comes on about age 45 to 55 typically. But we think the damage is ongoing for years before that. It's just that you have such CNS resilience or reservoir that you don't see the clinical impact of the smoldering inflammation, neurodegeneration, until you've lost enough reserve. And then you start to see the patient gradually deteriorate about age 45 to 55. So this is the comment of 2 distinct CNS inflammatory neuropathologies, one underlying relapsing MS, one underlying progressive MS. Everybody has both, probably early on. And you might ask, could we discover who had a dominant progressive component? Could we pick them up early? If we had treatment, we would want to start that early. So if we look at what we believe are the causal factors in damage in progressive MS, there's this smoldering CNS inflammation, including toxicity of glia, microglia being turned on to be toxic, astrocytes being turned on to be toxic, Neurodegenerative injury, what do I mean by that? That's injury to synapses where one nerve talks to the other. Injury to axons and injury to the neurons themselves. So there's a lot of neurodegeneration that makes up progressive MS. Age-related changes play a role in this. Oxidative stress and oxidative injury plays a role. Progressive mitochondrial dysfunction giving you an energy gap. There's not enough energy and cells start to die because of that, and energy failure. Glutamate excitotoxicity, there's evidence for that. Iron deposition that drives oxidative damage, that increases with age. Disruption of ion channels, axonal transport, negative secretory factors, and loss of the myelin trophic effect. The myelin helps to protect the axons. As you demyelinate more and more, you can injure the axons. You make them more vulnerable to damage, and that's driving the neurodegenerative. So these are all mechanisms of damage that have been implicated in progressive MS. The question is, do all of them play a role? Do some of them play a role? Can we figure out different subsets of MS that have different pathologies driving their progression? Because that would be where you would invest trying to develop specific therapies to repair this. Anti-microglia, anti-astrocyte, helping the mitochondria to salvage them. We really need to understand what drives progression in various MS individuals to try to design the best treatment strategies. I don't want to forget about aging. Understand there's immunosenescence. As the immune system ages, you have dysfunction, and you have a low-grade chronic inflammation that occurs with aging of the immune system. That promotes MS. Remember, inflammation is bad in MS. We treat to decrease inflammation, yet aging is producing more inflammation, chronic inflammaging, it's called. You can see obvious changes in the immune system, particularly after age 60, where you have increased infections, decreased responses to vaccine just based on age, decreased wound healing. So aging is a very important factor. And there seem to be big changes at age 44 and then age 60, okay? And actually, some people are talking about, should we be attacking aging as a treatment for MS? And this is interesting. Senescent cells are old cells. They accumulate with aging. They are pro-inflammatory, bad for MS. So senescent cells are bad for MS. They decrease regeneration of tissue, and they've been implicated in neurodegenerative diseases, including MS. They have their own unique factors that may be toxic that they're secreting. In fact, in a study of primary progressive MS, their neuroprogenitor cells failed to promote oligodendrocyte precursor cell maturation, whereas healthy controls did. So it seemed to be an MS-related deficit that was interfering with promoting remyelinization. And people are now talking about targeting that and perhaps trying to get rid of senescent cells or tackling aging changes themselves as a novel treatment for MS. This hasn't happened yet, but it's coming. And so senescence contributes to that damage of MS, and it may be a target to try to treat MS. We don't have those treatments yet, but we will, because everybody does want to combat aging and the bad things that occur with aging. How to detect worsening? If you think about the individual with MS and how they worsen, there's MS damage, there's their degree of CNS resilience and reserve. No comorbidities is better than multiple comorbidities like hypertension, diabetes, hyperlipidemia, depression, and anxiety. These are all negatives. Those are comorbid conditions that are negative, make it more difficult. And aging. Inexorable aging, that's not good. We all have to go through it, but that's not good. So PIRA outweighs RAW in every MS group with the exception of pediatric MS. We know progression can occur early. We know it can occur in people that look very good. So you have to be suspicious about it. You have to be looking for it and thinking about it. So how do we detect MS worsening? Well, the good old neurologic examination. The good old neurologic examination. What's the strength? How do they walk? What's their balance? What's sensation? How is their vision? Is that deteriorating? That should be something that the neurologist following anybody is able to keep track of. We don't all do an EDSS. That's done in clinical trials. There are very few centers where they routinely do an EDSS. That would be great, but time-wise, it can be difficult. But the timed 25-foot walk, that's easy to do. You don't need a physician doing that. That can be a physician's assistant. And that's a great analysis of the walk that can be quickly done in less than a minute. Typically, you have to mark out the 25 feet. You typically do it twice and average the results. You'd like the person to walk that as quickly as they can without an assistive device, but if they need to use that for safety, they obviously need to use it. That can be done every single visit. That can be used to track deterioration in gait. There's a 9-hole peg test. That looks at your hand function. How quickly can you get pegs in and out in your dominant and non-dominant hand? That just takes a couple of minutes. Again, it doesn't require a physician to do that, but that's something that could be tracked on a regular basis as somebody is followed. And then cognitive issues. Something like the Symbol Digit Modality Test, SDMT, only checks processing speed, but you can do it in a very short period of time. You might do that once a year. And then there are more robust cognitive batteries that may be done on a regular basis, okay? So you could worsen on the neurological exam, you could worsen with cognitive issues, and then exercise-induced transient worsening. You need to pay attention to that because that is a valid worsening. So the person may look fine as you're evaluating them, may look fine, but if you stress them by having them walk a mile or a half mile, et cetera, you might see deficits brought out temporarily by the exercise. That can be a sign of progression. Clearly, that can be a sign of progression. So how do you detect worsening? Well, ask the individual with MS is always a good starter because in theory, they're going to feel things and experience things that may portend progression. Ask family members that can observe them. Has this individual reduced or given up activities and why? That can be a sign of progression. Does exercise or sports bring out any problems? Has somebody needed to cut back on that? That would be a fair question to ask. Is there something that you were doing a year ago or 6 months ago that you're not doing now? Issues at work, that may represent progression. Patient-reported outcomes are key. There are a lot to look at various symptoms. There's also patient-reported outcomes that can help to figure out an EDSS score. An EDSS doesn't always need to be fully examined, but a patient-reported outcome can come pretty doggone close to telling you what an EDSS is. Do they have new or worsening symptoms like bladder, bowel pain, fatigue, spasticity, poor health quality of life? A patient-reported outcome can get that data in a very short page. On imaging, we use the MRI scan. Optical coherence tomography, that's an ophthalmological tool. That looks at the optic nerve, the back of the eye, the retinal nerve fiber layer. It gets a thickness. That should be equal in the right and left eye. If it's not, it indicates there's been perhaps subclinical damage to the optic nerve. The interesting thing about the back of the eye where the optic nerve is, there's no CNS myelin. It's pure axons and pure neurons. So you're getting a very good neurodegenerative measure of what may be happening in the brain. And some recent studies suggest this might be a good thing to follow on an annual basis to see if there's ongoing damage attacking the axons and neurons within the optical coherence tomography, the back of the eye. And then we're looking at blood biomarkers and composite measures. What does that mean? You combine them. So you might have If this individual is getting worse in the study, we're going to look at EDSS worsening, but we're going to look at time 25-foot walk nursing worsening, and we're also going to look at the 9-hole peg test. So you can worsen on any of those 3 factors, and that will count as progression. So a composite outcome where you combine measures and say, you don't have to hit all the measures, you can hit just one of these measures, but all of these are going to be features of somebody who worsened on the evaluation. Composite measures can be very powerful. And ultimately, again, we want to be able to predict who's going to progress and identify them, hopefully, maybe even before they've progressed. That would be the ideal thing. So monitoring issues. Current disease activity is mainly monitored clinically and by MRI scan. That's how we do it currently. And that should be explained and accepted as anybody is starting a new treatment. A DMT doesn't work right away. I tell patients it takes about 8 to 10 weeks before a disease-modifying therapy should be fully operational. So they may still experience problems in that first time. That would not mean that they were failing that disease-modifying therapy. You want to re-baseline the brain MRI. That's why typically, if you start a treatment or you change a treatment, you're going to get a new brain MRI about 6 months on that therapy. That's your new baseline. Because if they could have had new lesion formation closer to starting the new treatment when it wasn't operational yet. That's the concept of rebaselining. And quite frankly, our current measures, which are largely for relapsing MS, are not very sensitive. The classic relapse is falling. It's falling over time. We don't understand that. It's not just treatment, but the attack rate is falling over time. This may be environmental factors, people living healthier lifestyles, et cetera. Our attack rate is less in the modern era than it was 20 to 30 years ago. And quite frankly, MRIs of the brain are not very helpful in progressive MS because progressive MS has microscopic changes. The macroscopic changes are all being produced by the relapsing component of MS. And we're not following consistent MRI protocols. The biggest MS neurology experts in imaging from North America, Europe, and the Consortium of MS Centers got together and recommended protocols for imaging brain, for imaging spinal cord, and for imaging optic nerve. But most places don't follow that. They don't do an MS profile. So we don't have standardized evaluation. And it's clear that PIRA is being missed. So the treatment approach at the current time. If an MS individual has progressive MS, it's not that their course is inexorable. They may stabilize for up to a couple of years at a time, and there might even be the chance of improvement. You talk about health maintenance, wellness, and vascular other comorbidities that are very important. They're treatments. They're treatments for anybody with MS to help them to age better. You want to optimize symptomatic management as well. You don't want to neglect that. That's an important quality of life, health-related quality of life issue. We have an approved treatment for primary progressive MS, and it's important to evaluate to see if a progressive patient has a focal inflammatory component, because then they should definitely be on treatment to shut that down to a minimum. That's the relapsing component of the disease. So the single improved agent we have is ocrelizumab. That's a humanized anti-CD20. It's a B-cell lytic agent, and it's the single approved agent because it had a positive phase 3 trial against placebo. And the interesting thing is that works on the systemic immune system. It doesn't really penetrate into the CNS. That's about 0.1%. Yet you are able to impact, they were able to impact on primary progressive MS, despite it not truly getting into the central nervous system. But that makes you wonder, how would a treatment work if we did get it into the central nervous system? Would it work even better if that's the site of the key pathology for progressive MS? And with regard to secondary progressive MS, we had a big study, a huge study in secondary progressive MS for a second-generation S1P receptor modulator. That was siponimod. The problem was that when they analyzed the data, it was the secondary progressive patients closer to the relapsing phase that seemed to have the response. So they said, we're not going to approve you for secondary progressive MS. We're going to approve you for relapsing forms of MS, including first attack, which they never studied, relapsing MS, and progressive MS with an active component, an active relapsing component. So that data is there. These are the two agents that have some data where you might consider using them in progressive MS at the current time. But it's clear that we need more therapies. And here is the future. I'll talk about oral BTK inhibitors in a minute. We have a phase 3 trial in non-active secondary progressive MS. It's probably going to be closing soon with a brand new second generation agent, intravenous frexalimab. That's an anti-CD40 ligand that hits the adaptive acquired immune system and the innate immune system. And this has shown very good data in a phase 2 trial that was in relapsing MS. There's a big phase 3 trial ongoing in progressive MS, and we'll see if this turns out to be positive or not. CAR T therapy. CAR T is in its infancy in being applied to MS. What does that do? It really allows a personalized treatment, taking the individual's T cells, expanding them, and determining what you want those T cells to target, and then putting them back in the individual as an almost permanent treatment. So if you said you wanted to target CD20 B cells, you could do a CAR T strategy that would have T cells attack those B cells, okay? And people are experimenting with that now. Orovidoflutamist calcium. This is a very interesting oral agent that inhibits an enzyme for pyrimidines, DHOD. So that's kind of like teriflunomide. It would stop rapidly dividing lymphocytes, T and B cells, but it also activates NUR. That's a neuroprotective agent. So there are hints that it may have a benefit within the central nervous system, and there's ongoing trials, and they are studying that. And then a host of CNS repair strategies. CNS repair is not just remyelinization. CNS repair is brain-machine interface. CNS repair is exosome suits that allow somebody who is paralyzed to get up and walk around. It's causing sprouting of axons. It is remyelinization, but it's putting in new cells that can replace dead cells. There's a whole host of different approaches for CNS repair where you want to make somebody with fixed deficits better. This is being pushed by virtually all the major neurologic diseases, including MS. We don't have it yet, but we will ultimately within a couple of years. These are the BTK inhibitors that are probably very exciting. They target B cells and myeloid cells. They're oral agents. They don't kill cells, they block the activation of the cells. And you can design BTK inhibitors that penetrate into the CNS. And the myeloid target there is the microglia. The microglia are most activated in progressive MS. It's believed that activated microglia are part of the damage mechanism in neurodegenerative CNS smoldering inflammation, progressive MS. So the BTK inhibitors that are currently being studied are believed to penetrate and could clearly target the microglia. So there are several that are being studied, and there has been a positive phase 3 trial in non-relapsing secondary progressive MS, and that's the exciting news. That first one up there, these are the BTK inhibitors that are studied. Evobrutinib in relapsing MS failed. It may have failed because it didn't penetrate CNS very well. Tolebrutinib failed in the relapsing trials because it could not beat on relapse rate teriflunomide. They both had really low relapse rates, but it didn't beat it. But in the phase 3 secondary progressive trial, it slowed progression by 31%. I'll show you that in a minute. Fenebrutinib is going to read out their phase 3 primary progressive trial probably in November, and we eagerly await that. They went head-to-head against ocrelizumab in PPMS, randomized, versus their oral BTK inhibitor, fenebrutinib. Can that beat ocrelizumab? That's going to be a very interesting question. And then we have other ones that are being studied as well. This is from the Hercules primary endpoint, 31% decrease in progression. Honest to goodness progression in true progressing secondary progressive MS. That was highly statistically significant. This made it a positive study. They're in front of the FDA to see if they can get approved as a treatment. The FDA is supposed to rule by the end of December. And I'll just show you that in the same study, in their two identical relapsing phase 3 trials, they failed because they were supposed to beat teriflunomide on annualized relapse rate, and they didn't. But look at this curve. Now, this doesn't count because the primary outcome failed. So the study's over and done with. But this is looking at confirmed disability worsening over 6 months. The line separated in favor of the BTK inhibitor versus teriflunomide. It was going up against teriflunomide. So you saw a hint that this BTK inhibitor could slow worsening in relapsing MS, and we know that most of that is PIRA, not RAW. So it gives you a sense that this was a valid result in their phase 3 Hercules trial that was published in the New England Journal about 2 months ago. So how could BTK inhibitors be used? Well, if you had somebody that you said your real problem is progressive MS and PIRA, if it really holds up, this would be your drug of choice right now based on the data. Or you could take a relapsing component, treat that relapsing component first until it's in check, and then make a switch to hit the progressive neurodegenerative component. Or you could maybe combine both. Start with a medication for relapsing MS plus progressive neurodegenerative smoldering inflammation MS. You would have to do the studies. You can't just willy-nilly combine two drugs when you don't know what happens with it. You would have to do a formal study, but these are different ways of measuring that. This is an example of artificial intelligence machine learning. This looked at 3 trials. Only one was positive, oratorio. The Olympus study and the Arpeggio study were negative studies. This used AI machine learning to say, are there patients in these studies that responded to treatment? And there were. Now understand, if you have a negative study, you're not going to dig, or you're not going to be able to tell there's a subset that responded. The AI found that. It's just showing the power of how we're beginning to use AI for medicine. They were able to analyze all the data and come up with the fact that a percentage of patients actually seem to respond to the treatment. And this is something that we'll be using more of in the future. So future needs. We need to identify those who are destined to develop future clinical progression and PIRA. We need to initiate optimized targeted therapy. We need to optimize CNS reserve. We need digital tools, both active and passive. We see a patient for 20 to 30 minutes in the clinic, but what's happening most of the day? What's happening at home? What's happening over weeks, over months? Digital studies can track that, and that's going to be an important wave of the future. We need blood biomarkers and imaging biomarkers and even vision biomarkers. So let's talk briefly about neurofilament light protein. This is a blood test. You can measure it right now. There are commercial assays. It's starting to be used. This is an axon neuron injury component. It really goes up in the relapsing piece of the MS process with an acute attack, with focal inflammation, et cetera. It has prognostic significance. If you're treatment naive and newly diagnosed with MS and you have a higher level, that's a worse prognosis. If you go on treatment and your neurofilament light doesn't go down, that's a worse prognosis. We're going to be seeing this used increasingly in clinical settings. The second one, which doesn't have as robust a background yet, is glial fibrillary acidic protein, or GFAP. That comes from damage to astrocytes, another glial cell. It turns out this seems to correlate better to predict progression in PIRA than neurofilament light protein. This may turn out to be a very important blood marker that we can do to say this person is at risk for PIRA, for progression, or they are not responding well and we need to do something about that. And these are some imaging and vision biomarkers. Obviously, it's bad to have new lesions, but that's a relapsing component. Progression and PIRA are microscopic injuries. At some point, it seems like measuring particularly gray matter, brain area, but high cervical cord may be a great predictor for who's going to develop PIRA and progression. We don't do that routinely. This is the wave of the future, but it may be coming. This may be a great marker to select people that you are concerned about that. And we talked about those pearl lesions. PET scan will never come to clinical routine use. I think it's just too involved. But to really evaluate what a treatment is doing with regard to, did it change the microglia or did it change other metabolic factors? That's very important to give us insight and knowledge about what's happening in MS. I mentioned the OCT. I could imagine doing that once a year to look at the retinal nerve fiber layer. And another thing that has not come to typical fruition, if you use low contrast visual acuity, you can pick up deficits that you won't see if you're using the regular vision. When you think about the regular vision board, it's big black letters. The low contrast visual acuity is 2.5 to 1.25%. It's lighter, and you can pick up deficits that you don't see with a regular visual acuity board. So the future, we're going to see artificial intelligence, machine learning more and more. A human being can't go over 5,000 MRI scans, can't go over 300 bits of data. The computer can. We're going to see routine digital technology used. We're going to see routine blood markers. I think it's going to be first neurofilament light protein and GFAP. We're going to see OCT annually, I think. There are molecular techniques I haven't talked about that are very sensitive, and advanced imaging techniques. So to summarize, progressive MS is a major challenge. We have not identified yet the key drivers and their roles. We need early predictive biomarkers for who is going to progress. We need therapies for them. They need to be used early before obvious clinical progression, perhaps in combination strategy, perhaps as follow-up after a lapsing component is treated and contained. And these issues are high priority and need to be resolved. So I'm going to stop there and we'll call Stuart to come up to do the Q&A.
Awesome. Thank you so much, Dr. Coyle. That was a fantastic presentation. I haven't heard something like that in a very long time, and it may have been by you a long time ago, and yet, though, there's so much more to add to it these days. So thank you so much. For those that don't know, I am president and founder of MS Views and News. My name is Stuart Schlossman. We have a lot of new people online, and we have a lot of people in the audience. We are going to be starting the Q&A very shortly. I just want to let everybody that's in person, if you have a question, I need you to raise your hand so that those that have the microphones for my team can get around and to see you. We're going to take like 3 questions in person, and then go to online for a few questions. And because we do have a ton of questions online, and I'm hoping that we have as many in person, but I cannot see you in person. So if there are any in person, Vinny, if you could let me know, or let Jason know to let me know so we can get started somewhere. Is there anybody in person with a question?
Oh, hi. I'm Deb. I was wondering if you've lost muscle mass, are you able to build it up again, or is it gone?
Well, it's not necessarily gone. You can take a healthy control and cast their leg for a month, and you open the cast and the muscle will be atrophied. So disuse causes atrophy for sure. But then you work on a program, you exercise those muscles, you're using it, and you can definitely improve it. So that's not a fixed deficit. Disuse atrophy is a big deal. Okay, so you don't use it, you lose it.
What is a mid-normal vitamin D level?
30 to 100 is the normal range. I think a lot of people will aim for 50. The one thing you have to be careful, and you can take D3. okay, by mouth. The one thing you have to be careful about is if you have a history of kidney stones. So kidney stones are largely calcium. When you start taking vitamin D, you're going to absorb, you'll take in more calcium. So that would be the one caution that I would have. But normally we tell people to maybe aim for like 50 to 60, but not higher. You can also go toxic on vitamin D, so you don't want to go above 100. So 30 to 100 is the typical normal range for D3.
So as an older person, when can I stop taking medication if I continue to show no outward signs of MS?
Right. So this question comes up in somebody who is not considered progressive but has relapsing MS. If we have people over age 70, we do have a discussion about whether they would prefer to come off the medication, and we would follow them. I think it becomes a little bit more questionable. People have gone down to age 55. I think that's too early. 60 or 65. Now, one strategy that people are doing, you just need more experience, is measuring neurofilament light protein and then trying to monitor that as you stop the treatment and follow them as a sign that perhaps that was a mistake if it starts to go up. So the older you are, the more likely you are to be past the true relapsing component. But we don't have a good measure now to say it's clearly burned out in you. That's the problem.
So, doctor, I have a follow-up question to that question, and that is that there are many people around the United States, probably around the world, that have been diagnosed as relapse remitting or just RMS, even though they may have been SPMS, simply because the doctors wanted to be able to give them the opportunity to remain using medications. So, what happens going forward with people like this?
Very interesting. The ICD codes have changed a little bit, that now you can specify relapsing MS, primary progressive, secondary progressive. At the same time that's being heavily critiqued. And they have a committee looking at changing that because they'd rather be biologically driven. There was an interesting experiment where they looked at AI to examine a huge database and break up MS. And they found 8 different stages in 4 dimensions in this recent publication that was based on thousands of studies. Now, whether that'll come to fruition and we'll be using an AI-generated classification for MS, I don't know. I don't know if that's going to happen. But I'm saying it's been critiqued that it's too simplistic, and we used clinical ways to define those phenotypes, and we really should be using biological ways to define them.
Right. So going forward, though, with those new ICD codes, though, will that stop people from getting treatment that they cannot get, simply because with the new ICD codes, they'll be labeled something where they will be prevented from getting a certain medication?
Well, I think a lot of that will depend on the third-party payers, right? I mean, what do they say?
Okay.
You know, it's variable at this point in time.
I understand that Ocrevus, Ocrevus doesn't help with primary progressive.
No, that's not true. It's the one approved drug for primary progressive. I had said that.
Would any
Um,
of these drugs?
What I'm saying is that there's a question about, is it effective at what age, that you have to be younger. So they designed the phase 3 trial with ocrelizumab based on the Olympus study. So they used 55 as a cutoff. In real world data, up to 65 seems to show a benefit. And they just presented at ECTRIMS, which was held in Barcelona a few weeks ago, Oratorio Hand, where they had some wheelchair-bound patients that had benefits with ocrelizumab. And there they had the age like a little bit older. It was up to age 60, I think, if I remember correctly. But wheelchair-bound that seemed to have a benefit from ocrelizumab. The question is, will we get a competing BTK inhibitor? And you have a BTK inhibitor going up against ocrelizumab, which is very interesting to see who wins that or what happens with that.
Person writes, I have PPMS. Ocrevus did not work for me. So this was stopped 3 years ago. This happens with many patients. Based on what you said at the beginning of the presentation, can a doctor then put a person that was labeled as PPMS onto something else? I mean, right now, there's nothing for SPMS, but is there something else that a person can be put on?
First thing to understand is that there is no treatment for progressive MS that says it will stop progression. So ocrelizumab didn't stop progression. It slowed progression significantly compared to placebo treatment. Okay. So it definitely had benefit. There are some questions about what there may be an age limit, and the older you are, the less likely you are to see a benefit on progression. Now, I just mentioned oratorio hand, which has not been published yet. That was presented just a few weeks ago. That was interesting because they took a very even more disabled group and showed some benefits of ocrelizumab. I think, also progressive MS is more difficult to treat. To say that you're going to stop treatment would be extraordinary. You're expected to slow treatment, so you need to be able to have parameters that you can follow to see if the deterioration is significantly less than before you started the treatment. And that's not so easy to really tell, as you can imagine. But what we would like is some more treatments. And what's unique about the modern era, the later BTK inhibitors, they penetrate the CNS. That may make a difference.
If tolobrutinib is approved as for non-relapsing secondary progressive MS, would that prevent anybody with just secondary progressive MS be able to use it or not?
If I understand correctly, they went for an approval for SPMS or anybody having basically PIRA, which would give you, if they got that approval, that would be a pretty broad spectrum. So you could use it for anybody with PIRA or secondary progressive MS. So, we're going to see. We're going to see if the FDA, buys that and agrees. I should mention a very small minority of people that took the medication developed liver enzyme elevations, 0.5%, in the first 90 days, had to come off the treatment. So it's very likely, if that gets approved, that you would be doing weekly liver enzymes for the first 12 weeks. Probably.
Can you talk a little bit about neuroplasticity, and is there any way to promote that? Creating new pathways.
Right. So we didn't really mention this. It may have been on the slides. MS also interferes with circuits. Okay. So you have circuits within the brain that can be disrupted, and that may be that's likely to be part of the pathology. So for example, when you have people that have chronic pain, one explanation for that is that they're exciting circuits that shouldn't be excited in pain. Okay. So you can do certain studies in MS. The first thing would be to try to define what are the critical circuits using a technique called functional MRI scan. It's not so easy. So it would have to be a research tool that you would do. Understand that when you're doing a repetitive action, you're probably using a loop. Okay. So for example, people that can't walk a straight line, a tandem, if they practice that at home, they will improve that. They will get better on their balance because they're using a circuit for their balance that normally we don't try to walk a straight line. We never do that. So they can actually improve it with that. Circuits may be very important, and they can cause pathology in some cases. They're not that well understood, in my opinion, in MS and have to be studied. And functional MRI is not so easy to do.
Thank you. Going back to an online question as this keeps coming up. If the medical world is currently wanting to treat MS as all different forms of MS as one type of disease, then all these new ICD codes that are being put out there by the insurers, how will that work against all these new, against the one thought of MS being one disease versus the ICD codes?
So there is a discrepancy there. There absolutely is a discrepancy there. We're going to see what happens to the group that is reviewing the clinical phenotypes and what they wind up commenting and what they wind up doing. So that hasn't come out yet. Those meetings were held in like the fall.
I had a question on brain mass. Do you normally measure brain mass and loss? And how does it progress more?
Okay, so that's a very good question. Brain volume can be measured, and we are doing it in patients. Can you use it on an individual basis to make predictions at this point in time of their MS? And the answer would be no. Everybody would say no. So it turns out that there are multiple things that can influence brain volume, even when you do at the time of day. If somebody has an infection, they're dehydrated, they've been intoxicated, etc., you can have they've received steroids, you can have tremendous swings in brain volume measurements. So it's not quite ready for prime time. We are collecting that data because you have data sets that can analyze that. Okay, and maybe we would go back and look at that. Now, what seems to be helpful is gray matter, cortical and deep gray matter nuclei volume loss. That may be meaningful. And I told you about, we haven't paid enough attention to the spinal cord and the cervical cord and the cross-sectional section or atrophy in the cervical cord. There's studies suggesting that may be more meaningful than looking at brain atrophy. Think about progressive MS. We think about that classically as a progressive myelopathy, spinal cord disease. They often have a lot of changes within the spinal cord. So that's something that's being increasingly talked about to look at, and they've gotten better in measuring spinal cord. The toughest area of the CNS to image with an MRI scan is the thoracic spine, and you can see a lot of artifact. People call lesions and they're not there. They don't call lesions and they are there. So it's very important what sort of protocol you use, but the thoracic spine in particular is very difficult. Cervical is much better. And I think there are ongoing studies that are looking at volume loss there and how best to measure that, et cetera. So I think we'll be using it in the future, but right now, one-on-one, it's not ready to be predictive.
Regarding the coding system, again, with G35 being the current code for multiple sclerosis versus the ICD codes, what would you see as helpful to compiling a larger database and standardized uniform reporting for abstracting information for studies to be represented in the MS series?
Well, I think registries are very important. That provides real-world data. The first thing is to see what changes, if any, are made to the phenotypes, the clinical phenotypes. That'll be the first thing. And I don't know what's going to happen with that. So we need to wait and see what happens with that.
Okay.
Will we be using still the conventional terms or not? I think they wanted to get clear that there's probably virtually no MS patient that doesn't have a potential progressive component and a potential relapsing component. I think that was one of the big points that they were trying to make. But then something accounts for why don't people show a prominent relapsing component? Why do they just show a prominent progressive component and vice versa? And we don't have the explanation for that.
All right, thank you for that. Next, all around the United States, people are seeing now on television ads for stem cell treatments. And people want to know what you can tell us about what's happening with these treatments that are going on in the US versus the standardized HSCT that may be going on in actual clinical trials.
Okay, autologous hematopoietic bone marrow transplant is something special. They go through intense chemotherapy to destroy their immune system. You've harvested cells so you can replenish and give them a new immune system. That's intense immunosuppression. That's a specific type. Okay, so autologous hematopoietic stem cells is bone marrow transplant with a severe immunosuppressive course, knocking out the sick immune system and then reconstituting a naive immune system. And so that's a big deal. It's been recommended that this be relapsing MS, that they don't have MS for a long time, that they still have things to lose. And there's fairly good data in relatively small numbers that they do very well 10, 15 years out. Now, there are ongoing studies that are comparing high-dose efficacy DMTs with autologous hematopoietic bone marrow transplant, okay? In addition, there are a lot of places that say, come to my outpatient department, we'll collect your cells in the morning and give you back stem cells in the afternoon, okay? There is no documentation that that works for MS, none. This is a research tool. They don't know the best stem cells to use. They don't know the best amounts. They don't know the best route of delivery. They don't know how often to give it. Now, that may turn out to be a good thing. Maybe you don't want to give stem cells. You want to give exosomes, which are pieces of them. That may penetrate better. But that's a research study. People certainly shouldn't be paying money to get stem cells at the current time. It's not proven.
Okay, thank you so much for that. Next one, we have, people want to know about how AI is being used in MRI these days, such as Icometrics or similar companies. Can you tell us the reason for or what they're looking for in the new AI technology of the MRI?
AI is being used in medicine across, the board. So if it's used properly, I mean, you don't want to think about computers replacing people, and that won't happen. But for example, people are using it to record outpatient evaluations, to go through outside records, to rewrite or improve a document or a letter to give a differential diagnosis. And then AI machine learning is being done for specific techniques. I gave the example of the brain age based on volume loss. There are other ways to look at brain age because that might be a potential severity marker and something that would be very good to follow. And I gave another example where they evaluated trials, including 2 negative studies, and came up with a subset that responded to the study, which wasn't appreciated at the time. And then I gave the example of an enormous study, the Novartis Oxford database, where they actually evaluated MS and divided it into 4 dimensions and 8 stages, from mildest stage to more severe stage. Now, will that go anywhere? I don't know. That was published just, I think just about a month and a half ago or so, But it's interesting, it's
Okay.
being used across the board in medicine, and it will get better and better. But who's going to win? There's nothing that people would say, oh, this does the best brain aging. I need to use it in every patient. We're not there yet. You need multiple centers that are confirming this technique works, et cetera.
Okay, thank you for that. Next, AI, going back to another AI question. Do you think that AI will help clinical trials go faster?
It's possible. It may be good to determine who should be entered or looking at subgroups of patients where you can get, more disease active patients to enter. So that's possible.
Good, thank you. All right, another patient wants to know, when they go to see their neurologist, they're given these tests that they just don't understand the reason for it. Again, the 25-foot walk, them where they're sitting down in a chair and they're having to tap on the legs or turn their hands over, touching the nose. They want to know what all this is about. So if you could explain this, please.
So first of all, the neurological exam has 7 components. If you're doing a complete neurological exam, you're looking at higher integrative function, mental status, you're looking at cranial nerves, you're looking at reflexes, you're looking at cerebellar function, you're looking at sensory function, you're looking at gait, okay? That's a neurological exam, so touching finger to nose should be done in everybody. Okay, that's looking at your coordination cerebellar system. You want to see if somebody has cerebellar deficits. You want to look at somebody's walking, see if they do it in a straight line. So that's part of a complete neurological exam, which is separate from the classic medical physical examination. And that complete exam should be done in every new patient. Now, when the patients come back, you're doing it more selective. Of course, I want a timed 25-foot walk. That's great. I don't have to spend time doing it, and it tells me if the patient has worsened in that arena. And if it's 20% or greater, that's significant. So you already have that, defined. So that's going to be an easy way to pick up if somebody has a gait problem. Okay, so I want to do that. The 9-hole peg test actually evaluates hand function and dexterity. So that can show worsening as well. That's important to know. The follow-up neurological exam is going to be more limited, but we'd look at gait, motor. I would do some cerebellar, sensory, and vision evaluation of that. Everybody will do it a little bit different. But what you're really looking at is, do you find deterioration? And you're guided by what the patient, you just ask somebody, are you doing about the same? Do you think you're stable? Are you having any problems? And I pointed out that thing about exercise-induced issues, that can be a sign of progression. So you need to be thinking about, have I needed to curtail any activities or give up any activities? That's an important question.
Okay, thank you. Back to MRI, a person is asking, why does my doctor give me brain and cervical spine only? I've heard so much from others that they get lumbar and thoracic at times. So can you tell us the difference?
So lumbar doesn't have any central nervous system, so there's no point in looking at that in MS. Okay. However, you want to make sure that the conus, which is the bottom part of the spinal cord, which goes down to L1-2, that needs to be visualized on the thoracic study. So if that's not being done, then you may see the conus, the teeny tiny bit on the lumbosacral spine, but I don't do LS spines because it doesn't make sense. Again, I'm saying you want to make sure that the conus, the tip of the spinal cord, is visualized and you rule out a lesion. Rarely you can have a lesion there in MS, and it's more common in MOGAD, for example, which is in the differential diagnosis of relapsing MS. So you're really focusing on the cervical and thoracic cord, the thoracic cord to include the conus. You want to know if there are macroscopic lesions. Spinal cord lesions are bad. They're a poor prognostic indicator, so you want to know if somebody has changes there. When you're doing surveillance MRI scans, so the person's doing great and you're doing it because you want to make sure there's no surprise breakthrough of new lesion activity, it's typically done with brain. That has been the recommendation by all of the expert groups, and they don't think there's validity to routinely doing cord, including cervical cord. However, it has been said that if somebody has cord lesions, it's probably reasonable to reevaluate every couple of years, because you're also getting technically better at visualizing the spinal cord. It's harder to do that. So you might want to follow up every couple of years. But the typical surveillance MRI scan is a brain MRI without contrast. So you're being compared to say, are there any new lesions or larger lesions? And then if you need to go back and do contrast, you can, but you don't routinely do it. And the brain is the one that's recommended.
Thank you. So bringing up contrast, just throwing this in, why is contrast not used as much as it used to be used?
Because it deposits in the human brain, and though there's been nothing associated with that, they're worried there might be something bad about that. So they say, don't use unnecessary contrast. So if somebody's doing great on their DMT and you have a good baseline, you can tell if there are new lesions or significantly bigger lesions. You don't need to give contrast.
Okay, thank you. And also in the MRI, it was brought up recently that patients should ask the technician to make sure that they get information about the central vein as well as the pearls. Can you tell us about this?
So the 2024 revised diagnostic criteria don't necessarily mean you have to use it, but allow you to use the 6-vessel central vein sign and pearls. Those are special MRI techniques that can give you diagnostic greater specificity. The problem is that they've been used in research for the last 7 years. They have not been used in common clinical practice. Now, the big MRI makers do have the ability to do that, and I'm not sure technically what might be involved. What you need is to make them clinically available, and I think it would improve particularly the central vein sign, our accurate diagnosis and decrease the misdiagnosis rate, but they're not used right now clinically. So we're going to see what impact the new criteria have to see if they could be added on to the clinical MRI scan, which nobody is doing it clinically right now. It's a research tool, but could be easily used. They have it down to not much extra time.
The Octave MS test, the MSDA. Can you please tell us about this? And I heard that there's been a little benefit for Octave this week, so maybe you could discuss all of that, please.
I'm not sure of the benefit of Octave right now, which looks at 18 different biomarkers for MS. They've included neurofilament light and glial fibrillary acidic protein, and I think those are very important. But even they are not standardized enough. Like, should you be using, for neurofilament light, a Z-score? Probably typically to correct for age and BMI features. I think the Octave uses extra stuff that I'm not sure has such a great benefit. Now, I'm open to, being persuaded, but I would think that the more logical thing to me would be to try to really perfect the use of neurofilament light and GFAP. The best data is there for that. GFAP is not even as far along as neurofilament light rather than Octave. So I'm not personally using Octave.
Thank you. So we're talking about this, you and I know what this is all about. There are hundreds online right now. If you can let us know, and for those and that are in person, for those that don't understand what this testing is all about, can you explain it, please?
They were looking at blood biomarkers for MS, and they said we have 18 that characterize MS. These are valuable to do. And then they marketed that.
Okay. So with the neurofilament light or the Octave test, are they able to foresee using these new biomarkers what a patient might be going through in 6 months to a year from now?
So my problem is I believe in the value of neurofilament light and GFAP. I'm not sure about the other, 16 biomarkers in Octave.
Okay, fair answer. Thank you. Next patient is asking if a patient is ataxic and uses a walker, should the 25-foot walk be done with a walker or a cane so the ataxia can be assessed?
So you want to do the time 25-foot walk with the least assistive device. If you can do it without an assisted device, that's supposed to be better, even if you're slower than with an assisted device. But you need safety. So if you're going to try to go without an assisted device and you're going to fall and risk harming yourself, then you use that assisted device. So that's, a dialogue that you would have, kind of common sense. If you're worried that somebody's going to fall and potentially damage themselves, you wouldn't want that to happen. But in theory, the least that you need to use, if you can do it, is the preferred approach.
All right, next question is, can you tell us, please, the difference between spasticity and leg cramps? And can you tell us about the tightening, what people should do at night, restless leg syndrome, things like that, and what is best for them to have a peaceful night without much pain?
So spasticity is increased tone. So signs of that might be extensor spasm, where your arm straightens out uncontrollably, or the leg straightens out uncontrollably, or bends uncontrollably. And if you actually moved it with your hands or tried to move it with your hands, you'd feel how tight it was, okay? Now, spasticity is a symptom that you see with motor dysfunction in MS. Now, it's not necessarily bad. Spasticity can give you anti-gravity strength that may help you, stand better or even walk better. But if the spasticity is causing pain, that's a quality of life issue that would say it should be treated. If the spasticity is stopping maneuverability or interfering with how you position your body or how you're trying to go to sleep, then that would be something to treat. Now, doing stretching exercises for maybe 15 to 20 minutes can improve spasticity for up to several hours. So that sort of natural stretching is very good. There are also treatments that can help spasticity. The primary would be baclofen and tizanidine. And you could certainly take that. Those drugs are in your system in 30 to 60 minutes. They hang around 5 to 6 hours. So if you need to have it around the entire day, you would be giving it several times a day, but you don't have to. This is a symptomatic treatment, so you're giving it when you seem to need it for that 5 to 6 hours. So if you have spasms at nighttime, you might want tizanidine. That may be good. They both hit central receptors, but they have different side effect profiles. You can combine both at lower dose and see how someone responds.
Excellent, thank you. Next one is, has to do with, a lot of people talk about that they can't look up. They can't walk and look up at the sky. It makes them very dizzy. They just about fall down. Can you tell us the reason for that and why not to do that?
So we have a peripheral inner ear issue that has a semicircular canal and labyrinth. You also have some vertigo components that are central in the brainstem. Now, I think if you get bad vertigo, which is either the room spinning or you're spinning, and it's with significant nausea and vomiting, the chances are that's peripheral from the inner ear. That would be connected to movement of your head and neck. That can be such profound vertigo that you can't lift yourself up from bed for a couple of hours. You might have very bad nausea and vomiting. And there are actual evaluations that they can do to determine it's likely peripheral and a set of exercises that may help to shut it off. If the vertigo is not so severe, then it may be that it's coming from a central basis, and that tends not to have the prominent nausea and vomiting. And there may be ways that you can look at that. You can do maneuvers that suggest a peripheral versus a central cause of the vertigo with positioning, so that can be helpful in that particular examination.
Okay, thank you for that. Going back to the spasticity or cramps, what happens when a person wakes up during the night and their toes, their leg, their feet are curled up and they can't seem to get it to release without having to like step on the top of the foot? What do you suggest for this, please?
So I think with aging, you can get a little bit of dystonic posturing as well as you can get muscle cramps. I'm differentiating that a little bit from spasticity, okay? So you can see that with aging. Sometimes you can have deficiency in things like magnesium or potassium, et cetera. Massaging that should help as well. If it's getting very bad, happening often, or spreading to other parts of the body, then I think you may need to be evaluated for that. But like dystonic posturing at times, and then muscle cramps, and there are some home remedies that people use and over-the-counter things that can be tried first. It depends on, how often it's happening, or is it very limited?
Great, thank you. I have two questions remaining. You're going to love them both like all these others. Smile, please. And the first one is being older means, you were saying earlier, could mean worsening. If yes, then why are there so many neurologists that want their elder patients to get off of medications because they think that they've been doing so well?
Well, I think right now we don't have data to absolutely support that. So I think it should be, the patient should have important shared decision-making in that. So if I have somebody that feels that you're telling me maybe I don't need the treatment, but I feel better being on it, I think it's helping me, I don't want to give it up, I'm not having adverse events, and I think I'm being helped, why would I force them to come off? That makes no sense. Okay, I would leave them on. But if I discuss that with somebody and they say, you're right, I'm tired of taking this, I don't think it's doing anything, I would like to try coming off, then I would support that if I had initiated, the conversation. That would be the logical approach to that, I think. As we look for biomarkers like maybe the neurofilament light or others or better data, it's interesting that after age 60, 0.5% of the brain is atrophying in healthy controls. And in MS, it seems like it's aging-related atrophy as opposed to disease-related atrophy. That seems to be the earlier component. But after age 60, it looks like it's matching normal aging.
Great, thank you for that. Now, you as a professional MS neurologist, you're an expert, you're in a big town area. Most neurologists like yourself that are in larger communities have that same approach to the population. But when you get into the rural areas of the United States and you have your community neurologists, they don't agree with this. And so how can we get the word from your perspective, from the professionals that are in the big cities to those doctors that are in the rural, more rural, and smaller communities around the United States to benefit their patients?
I think it would be very good for such patients that only see a little bit of MS and aren't knowledgeable about it. And I don't blame them. You have to study hard to keep up on MS because there's so much happening. It would be good if they partnered, even by telemedicine, with a major MS center. So they could do that with regard to the decision-making on treatment and recommendations, or maybe that person would make one visit, even if it's 4 hours, to that MS center. They could have a relationship and then maybe follow up once a year on telemedicine or something like that. Just think about it. Would you rather go to a doctor where 80 to 90% of what they see is MS, or it's less than 5%? You can't remain up on any field in neurology now. You have to, you have stroke specialists, you have epilepsy specialists. They're just not going to be as good if you're doing everything. But you can partner now. You can partner easily with MS centers, I think.
One person writes, "Wow, Dr. Coyle is amazing. This is one of the best guests you've ever had. Great session. Thank you." Michael should know he's on many of our programs. And I can't say Michael because it's a very common name. So kudos, Dr. Coyle. All right. Next one is person writes, "Can controlling C17 cell therapy be less risky and healthier long-term treatment for progressive MS patients than treatments like Lemtrada that wipe out red and blood cells and leaves the body at risk due to very low immune system?"
Well, alemtuzumab doesn't have a large use now. I mean, it's a high efficacy monoclonal antibody, but it has a REMS program and black box warning. And you need to be monitored with monthly blood and your analyses for 4 years after the last dose. So it's not used that often. What was the first treatment that they asked about?
I'm sorry, but the question disappeared, so I can't even read the questions.
So what I'm saying is alemtuzumab is not used very much anymore.
Okay. All right. Thank you for that. The final thing that I'm going to ask you is your outlook on what's happening in the world of MS for the next 5 years.
There's a real focus on 2 areas that have been neglected: progressive MS. Now, understand, I don't blame people for going for relapsing MS. That was the main form of MS. That's how 85 to 90% present. There's now a focus on getting treatments for progressive MS and understanding progressive MS and PIRA and this whole concept. In addition, CNS repair strategies, which we need. Multiple neurologic, Alzheimer needs it, Parkinson's needs it, ALS needs it, spinal cord injury, Christopher Reeves needs it, traumatic brain injury needs it. We need CNS repair strategies, and we need treatments for progressive MS. And I think you're seeing greater and greater focus on trying to establish that. And I think AI, machine learning, is going to help us. Okay, I think we have to be a little bit careful, but its ability to look at so many fine points and helping to address it properly. Of course, it has to be supervised by people, but it's going to make an enormous difference ultimately in medicine, among other areas.
Thank you, Dr. Coyle. We do have two special guests that are coming up that are support group leaders from the National MS Society. They will be discussing their support groups for about 90 seconds each.
Good evening, everybody. My name is Raymond Schnell. I'm living with multiple sclerosis. I'm a group leader for the Wantor Support Group, and I just want to thank Stuart for having this event tonight. We really appreciate it. And for those who are living with MS, we have our meetings every third Tuesday at the St. Francis Church in Wantor. It's a great organization. It gives everybody a chance to talk about the stress and everything that goes on with MS. And it's, as many know, it's very difficult, and I'm very thankful for it. I'm thankful for my wife, who's also a caregiver, and we're just very thankful. And our mission is to prove living with MS, it's not all gloom and doom. Donna?
Thank you.
Am I holding this right? Okay. We started the group because we wanted to not be depressing. We have a group that's very informative, but we're very social, and we have different people every month to speak. And we've all made a lot of friends from the group, and sometimes we have like 25, 30 people. And Christine, the person who sets up everything, she sets up all the speakers. They're all different speakers. It's not all, don't get offended, but it's not all drug companies. It's different kinds of speakers and different exercise and different programs. And it's just a group. And we started it 20 years ago. And since then, it's grown from like 8 people to like 30 people. So if you want to come, like he said, it's St. Francis in Wantor every third Tuesday.
Awesome. Thank you so much. Again, thank you everybody for being online, and I'm going to say goodnight, and I hope to see you online again in a couple of weeks. Thank you. Bye-bye.